respect everyone's time this morning. So my name is Darren McNally, and I'm going to introduce our speakers today, two outstanding members of our community. We'll begin with the land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contributions to this land. Our presenters today are Dr. Thacker, who is a pediatric neuro-oncologist in the Division of Hematology Oncology, and Dr. Wilson, who is a staff pediatric radiologist in the medical imaging department. So I'll give you a little bit of background on our two speakers. Dr. Thacker has worked in pediatric oncology across 3 continents. He did his master's in pediatric oncology at Tata Memorial Hospital, one of the largest oncology centers in Asia, with nearly 2,000 pediatric oncology cases annually. He subsequently worked in clinical drug development at the Royal Marsden Hospital, a leading institution in early phase cancer trials in the UK. He then completed additional hematology oncology fellowship at SickKids, followed by a fellowship in pediatric neuro-oncology. He is currently working here at CHEO as one of our pediatric neuro-oncologists. His clinical and research interests include early phase clinical trials with novel cellular therapies, and he's presently leading 2 multinational Canadian pediatric neuro-oncology clinical trials. Well done, Dr. Thacker. Dr. Wilson is a staff pediatric radiologist in the medical imaging department at CHEO, an assistant professor of radiology at the University of Ottawa. She joined the medical imaging department in 2018, and prior to joining CHEO, she was a staff radiologist at the Montreal Children's Hospital and assistant professor of radiology at McGill University from 2012 to 2018. Dr. Wilson is the co-lead of neuro-MRI in the department, and she is a member of several committees, including the Medical Imaging Research Committee, the Pediatric Neuroradiology Committee with the Society of Pediatric Radiology, a member for the ACR, ASNR, SPR practice parameter for the performance and interpretation of MRI of the brain. Her clinical interest is pediatric neuroimaging. Her research interests pertain to neuroradiology with a special interest in patients like NF1, pediatric carry, non-accidental injury, and child maltreatment, epilepsy, and vasculitis. Dr. Wilson has a special interest and is actively involved in education and teaching. They'll be presenting today on the many faces of NF1, imaging, and managing. Well done. Please take it away.
Thank you. Thanks, Dar, for the kind introduction. So let's start with a talk for today, because we're mainly going to focus on the varied presentations that NF1 have and how do we go about managing this challenging patients who have multiple requirements. To begin with, I think it's a great month to start with this talk, because May is actually the NF awareness month. So starts on with the perfect timing, and this is great. So let's celebrate the NF awareness month with this talk at CHEO. So these are the objectives we'll be quickly brushing through while we are going through the talk. And so to quickly jump on the talk, let's start with the historical phases of NF1. So we all probably know this gentleman here, who is von Recklinghausen, as NF1 was always known as von Recklinghausen's disease. But how are Dr. Smith, who is of the fame of Smith's fracture, and Rudolf Virchow, who will excite our hematology colleagues because he's the man with Virchow's triad, the famous Virchow triad for thrombosis, how are they two related to NF1? So interestingly, the first systematic review of 6 patients of neurofibromatosis, it wasn't known as neurofibromatosis then, was published in 1849 by Smith, and he called them neuromatous tumors. Subsequently, Virchow described a lot of neuropathological features of neurofibromatosis in a series of reports from 1847 to around 1863, but he called them neuromas as well. Eventually, it was von Recklinghausen, who was actually pupil of Virchow, who described a case report with 35 cases. And he was the one who actually thought that they had both the components of neuronal component and the fibromatous component, and described them in 1882, which was 33 years after Smith initially actually described that, which is why his colleagues honored him by naming the disease after him. So moral of the story, keep your colleagues happy. Moving on, so neurofibromatosis is actually, as you all might know, is a heterogeneous multi-system neurocutaneous disorder. It is inherited in autosomal dominant fashion. In almost half the patients, it's inherited, while in the other half, it is actually de novo, the mutation. It has got 100% penetrance though. However, the expression is very variable. The genotype and the phenotype expression is pretty variable, and we still are learning a lot about genotypic phenotypic correlations, and it's not well established barring a very few mutations. Roughly around 1 in 3,000 live births are affected, and it also has got a population prevalence of between 1:2,500 to 1:4,000. It is actually one of the most commonly inherited CNS disorder, tumor syndrome, and molecularly belongs to a category where the RAS pathway is activated. So it's called rasopathy, and it is actually the most common rasopathy as well. So, so a lot of credentials to its CV. Since initially the establishment of the diagnostic criteria in 1988, the criteria weren't revised, and there were a lot of developments in the molecular field, in imaging, as well as we learned about a lot of other disease which was similar to NF1, especially Legius syndrome, and therefore in 2021, which is last year, they actually revised the diagnostic criteria for NF1. And essentially, they just simplified it and made sure that they included mosaics. But to put it very briefly, there are total 8 criteria, of which if 2 are positive, then you can make a clinical diagnosis of NF1. You don't need a genetic mutation or the genetic analysis to actually label it as NF1. But if you have one, then you will need just one other criteria. So just a mutation by itself will still not make it NF1. You will need the other criteria. So basically, at present, and if you see, the first author in the most consensus guidelines was Legius, of the fame of Legius syndrome, because he realized it was confusing with his disease, which is named after him. So they eventually now have a better consensus for 2021. Let's move on to the clinical phases of NF1. So as we discussed, NF1 is a heterogeneous neurocutaneous syndrome with addition affection of multiple organ systems, predominantly skeletal and cardiovascular. And just as a snapshot, if you see, almost 40 to 50% of the patients with NF1 are going to have plexiform neurofibromas, and almost 50%, half the kids with neurofibromatosis 1 are going to have some form of neurocognitive deficits or learning disorder. And almost a quarter of the patients are going to have scoliosis. It is also one of the most commonly inherited tumor predisposition syndrome, and they carry a lifetime risk of malignancy of almost 60%, and the most common being the low optic pathway gliomas, which account for 15 to 20%. So in view of the heterogeneous presentation and complex need of NF1 patients, they actually need regular follow-up with medical team, as you can understand. And American Academy of Pediatrics has well-established guidelines at present, which recommends the follow-up of NF1 patients. And interestingly, these guidelines have also been updated in 2019, because I think the earlier ones were in 2000 or late 2000s. To summarize, what they need is just a good physical exam. So a good physical exam, which includes growth, neurological exam, and a good cardiovascular exam annually. They need, ophthalmologists are your best friend for the disease. They need eye exam at least annually. Some of the groups actually recommend to have it 6 monthly for kids who are less than 6 years of age. At present, there is no routine screening imaging which is recommended for these group of patients, and all imaging needs to be symptom driven. However, there is a building consensus that especially for kids who are younger than 6 years of age, because an ophthalmic exam is also difficult for them, it's sort of catching steam if these group of patients might warrant a screening MRI going forward. Also because the most of the patients who need treatment with optic pathway gliomas belong in this age group. However, it's all sort of more of discussion, but at present, there is no routine recommendation for imaging, and it's only symptom-based. So radiological imaging in NF1 is pretty complicated, primarily due to varied presentation and ongoing efforts at standardizing assessments of response to the newer therapies. So in light of that, I will now hand over to Dr. Wilson, who will simplify various radiological phases of NF1.
Thank you, Nirav, for that. And I will share my screen now, but I don't know where is to share. Actually, I don't have the option to share. Oh, yeah, I've got it. So can you see my screen?
Not yet.
Not yet.
Okay.
It's
Perfect.
coming here now.
So
It's
Here we
very
go.
small though.
very small. Okay, what can we do about it? I guess because I'm doing it from my workstation, that's why it is appearing to be that small.
I see that very well. It's the radiological phases of NF1.
Yes.
So it's good. It has a good size for me.
Okay.
How about the others? Sorry.
Usually it fills the entire screen. It is probably, it is good enough to proceed. We'll let you know if there's anything we need you to zoom in on.
Okay. So thank you, Nirav, for this nice introduction about NF1. And, you know, he mentioned that it is a clinical diagnosis, and I do agree. So imaging plays an essential role. I wrote here in the diagnosis, but sometimes the patients are not really diagnosed. So it is important for the radiologist, and it is crucial that they understand the different imaging features of the NF1, because we might encounter a situation where a child who is not diagnosed with NF1 and he has a lesion, and we need to look at that and put it in the right context, and maybe it helps us in allowing the prompt diagnosis and the appropriate management. It has some role in the surveillance and the follow-up in the lesions in individuals with NF1. It should be noted as well that a standardized approach to defining the response is essential in this era of newer therapies. So let's start by seeing the different radiological phases of NF1. But in this talk, we are not going to go into everything. I'm just giving you just few glimpses of the phases of NF1. And we'll start with the CNS manifestation of NF1. We can encounter the focal areas of signal abnormalities. We can see optic nerve gliomas. We can see low-grade gliomas and high-grade gliomas. So let's jump in and look at some images. So in this one here, we can see that there is marked enlargement. This is an orbital imaging for a small child, where we can see marked enlargement and tortuosity of the intraorbital and the perichiasmatic segment of both optic nerve. There is tortuosity of the optic nerve, as we can see it here in the sagittal imaging, and there is a little bit of hyper-intense signal. In the post-contrast images, we can appreciate the diffuse enhancement of both optic nerves, which is more on the right side. Multiple follow-ups has been performed to this patient, and after 2 years, we can appreciate that there is interval improvement in the thickness of the optic nerves on both sides. There is still tortuosity. There is more prominence of the subarachnoid spaces surrounding the optic nerves, but there is significant improvement of the enhancement. And the optic nerve gliomas, as Nirav mentioned, they are occurring in 15 to 20% of children with NF1. Usually they occur anyway along the optic pathway, starting from the intraocular segment, the prechiasmatic, the postchiasmatic, and in the optic radiations as well. And radiologically speaking, we would like to help localization. So we say, for example, this one is an anterior optic nerve tumor. But in this example here, we see a lobular mass lesion, which is centered at the level of the optic chiasm and the hypothalamus. On the T2, it appears to be of isointense signal to the gray matter, and in the post-gadolinium sequences, it is not enhancing. So this is a posterior optic nerve gliomas, and the follow-up after some years shows that there is no actual change in the size of this tumor, but there is interval development of some enhancement in the prechiasmatic segment of the optic nerve, and we call this a posterior optic nerve gliomas. They are low-grade gliomas. but they have a very indolent course and they are variable. Their natural history is really very variable. So some of the cases, we are going to see them starting as optic nerve thickening, and then they improve even without treatment. Some of them, they will receive treatment and still we are seeing every now and then a new area of enhancement. So their pattern or their natural history is not well understood and their behavior cannot be really anticipated. But in some of the publication, they mentioned that symptomatology-wise, the posterior ones are more symptomatic and maybe will need more treatment. So this is in terms of the optic nerve glioma. Is there anything else which we can see in the orbit in this group of patients? Yes, we can see that some of them, they might have like sphenoid wing hypoplasia, and as a result of that, there is anterior and medial expansion of the middle cranial fossa, which is encroaching on the suprasellar CSF cistern. And sometimes there is association with this sphenoid wing dysplasia, which is the plexiform neurofibromas at the level of the cavernous sinus, as you can see in this patient with the enhancement and target sun. Sometimes you do have increase in the anteroposterior diameter of the optic nerve of the ocular globe, and sometimes even there is retinal disease. So there is multiple pathologies or imaging appearances in addition to the optic nerve gliomas, but by far the optic nerve glioma is the commonest which we encounter in this group of patients. After looking into the images into the orbit, let's take a look at other findings in the brain. These are axial flare sequences, which is showing the presence of multiple foci of flare hyperintensities in different locations. So here they are in the globus pallidus, in the posterior thalami, in the hippocampus region, in the brain stem, as you can see here, in the midbrain, and in the pons, and in the posterior fossa, in the cerebellar white matter, and in the peduncles, and in the dentate nuclei. This is what we call the facie lesions or the focal areas of signal abnormality. They have these characteristic locations. They tend to be present in 60 to 85% of children with NF1, and it is postulated that higher lesion burden may be correlated with the cognitive outcome of these children. They are not present in the first 1 or 2 years of life, and then they start appear in younger children until the age of 10 maybe. Once they reach teens, they decrease in number and size, and after that they completely resolve by the adult age group. In terms of imaging, they should be differentiated from low-grade gliomas. The point is that on imaging, most of the time it is an easy call because of their classic location and the fact that they do not enhance and they do not show positive diffusion restriction. So how the low-grade gliomas will look like in the brain. So let's take a look here at this patient. This patient, this is an axial T2 at the level of the midbrain and at the level of the cerebellar hemispheres. And in this patient, we can appreciate the presence of a well-defined rounded lesion, which appears to be very hyper-intense on the T2. It is causing some expansion of the midbrain, and there is a little bit of surrounding edema. The same here, it is very hyper-intense and there is some surrounding edema. When we do additional pulse sequences, for example, like the diffusion, since they are low grade, I'm not expecting us to show a positive diffusion restriction, but in the gadolinium sequences, we can appreciate that they are enhancing. So these lesions, we can differentiate them on imaging. Sometimes they are problematic and we need to do like multiple follow-ups in order to make up our minds whether they are real tumors or they are just facie lesions. But once they start to show this mass effect and the edema and they show positive diffusion, enhancement, we categorize them as low-grade gliomas. And this is the follow-up of the lesion. As we can see here, there is interval decrease in size over time and decrease in the pattern of enhancement in this middle brain lesion, but the cerebellar lesion, it has decreased in terms of signal, but there is no enhancement, and this group is the low-grade gliomas. They occur in less than 10% of the pediatric population, and again, their course, when you study the natural history, it is still poorly understood. Some of these lesions will disappear completely, not completely, or decrease in size without treatment, and some of them, they they are going to need treatment, and for that we need to have like some sort of a criteria to show a radiological response to this treatment. And it is agreed that the RAPNO response criteria for the assessment of the pediatric low-grade gliomas is going to be used in this context. So complete response means the disappearance of all the T2 and the T2 flare and the contrast. Partial response, it is 50% or greater reduction in the size of the target lesion on T2 and flare, and variable changes in the enhancement, because the enhancement can be variable. Some advocate for the use of a minor response in some of the studies, and it is defined as between 25% and 49% reduction in the tumor measurements. And stable disease, there is neither increase or a decrease in the tumor size to qualify it as either a progressive disease or a partial response. The second thing is there high-grade tumors which can happen in this group of patients. I guess there is, but it is a very minimal group of patients which we have seen. I have only seen 2 patients of high grade throughout my career, and this is one of them here. At the age of 3, this is the MR, and it is only showing this FACI lesions on the axial T2 weighted sequence, and the sagittal T1 is completely normal. And then the child by the age of 16 started to be symptomatic, and we started seeing a lesion in the pineal region here, which appears to be iso-intense on the T2 weighted sequence, hyper-intense on the flare, and because of its location, it has caused hydrocephalus. As you can see here, the patient is having transepidermal CSF flow permeation. The diffusion, it shows a little bit of positive diffusion restriction. There is some drop of signal on the AJC map. And if you look into the contrast, it seems to be heterogeneous. So because the percentage of children with the high-grade tumor is less than 1% in this population, a follow-up was performed. So it showed that there is increase in the size of the tumor. And I'm going to show you the different, images throughout the time. And in the meantime, a biopsy was acquired and the patient received treatment, but despite that, it continued to grow. And this was a high-grade glioma with ATRX mutation. The second patient here presented with a headache. But these high-grade gliomas, in spite of the fact that in the literature they mentioned that they occur more towards the adult age group, but because what is published in the literature is only small case series, some of them, they are not going to read the book. So this child was 8 at presentation, and he has a mass lesion at the right thalamus. And as you can see here, it is partly cystic, partly solid, and the solid component is a little bit hypo-intense on the T1 weighted sequence. And there is significant edema surrounding this mass lesion, and it is exerting mass effect. And this is the post-GADU, which is showing intense enhancement in the solid component and in the capsule and in the septi, and there is positive diffusion restriction. And this was proven to be a giant cell GBM. And as I mentioned, in terms of the publications, there is only few case series which is published, and one of them was published in the AGNR, and they have only five cases to present in this paper. And it was proven that 4 of them was high-grade glioma and 1 was low-grade glioma. But the imaging features does not differ from any high-grade glioma in the general population, so there is nothing specific about them. We are applying the same rule as we apply it to the general population in terms of the radiological diagnosis. By this, I have finished the part about the tumor. Let's move on to another thing, which is the vascular dysplasia. This is an MRA of one of the NF1 patients, and we can see here that there is significant attenuation of the M1 segment on the right side with interval development of some collateral consistent with vascular dysplasia and moya-moya disease. This is another patient where we can see like a small aneurysmal dilatation on the left side. And this is another patient where we have stenosis at the level of the internal carotid artery, and this is the axial images for this one. So these patients some of the patients of NF1, about 3 to 7% of children with NF1, they can present with CNS vascular dysplasia. But it is not, strictly in the CNS. We can see them as well in smaller children or in other parts of the body. And this is a 5-year-old patient who presented with hypertension, and they wanted to rule out renal artery stenosis. The first MRI showed that there is discrepancy in the size between the right kidney and the left kidney. MRI was not very diagnostic, and this is another follow-up which is showing progression of the decrease in the size of the right kidney. And the Doppler evaluation demonstrated a very high velocity within the right renal artery, and in the intrarenal vessels there was a tardus parvus sign, and this represents a renal artery stenosis. And children with hypertension represent maybe around 16% in the NF1 population, and they are mostly secondary to renal artery stenosis, but we can encounter causes secondary to coarctation of the aorta and pheochromocytoma. What about other manifestations of the NF1? So this is an axial CHEO and axial flare of one patient, and we see here like a well-defined lesion in the scalp on the left side, and we have multiple other lesions in the right posterior parietal, which shows a target sign. And this is another patient where we have a well-defined lobulated lesion in the anterior chest wall. And this represents another group of imaging, which is the neurofibroma spectrum, which is a benign tumor which can occur everywhere in the body. And morphologically speaking, they can be divided into the localized form or the diffuse form, as you can see here. So here we can see them diffuse, ill-defined, and they are present on both sides. And even they can be very superficial, where we are seeing like thickening and plaque-like appearance of the superficial neurofibroma. Sometimes they can present as well morphologically as a plexiform neurofibroma. And this child presented with a mass lesion in the hand. On ultrasound imaging, it appeared to be very non-specific. You are having multiple hypoechoic lesions here. Some of them is showing internal vascularity. It is not classic for a vascular malformation, and it is one of the differential diagnoses when you are encountered with this pathology. So the child was referred to do an MRI to further characterize the lesion. And as you can see here, it shows like a bag of worm appearance on the coronal IR sequence, and in the post-GADO sequence, we can appreciate that there is central enhancement, and this is what we call a target sign. There is some incidence of malignancy which can happen in these plexiform neurofibromas, and radiologically speaking, clinically speaking, when there is sudden increase in the size and there is pain, radiologically, when we see that we have like perilesional increase, perilesional edema, increase in the size, cystic changes, sometimes the calcification, drop of signal on the ADC map. PET as well can be used in the evaluation of this malignant transformation, and it has a high sensitivity for the detection of the malignant transformation in this group of patients. This plexiform neurofibroma can happen anywhere in the body, and sometimes when it is deep, when it is superficial, it can cause disfigurement. But when it is deep, it can encroach on important structures. For example, let's move on to this patient here. This is a spinal plexiform neurofibroma, and it is huge plexiform neurofibromas along the whole spine, as you can see here, and we have the characteristic target sign. Another example here is a child who presented, he's a 4-year-old child who presented to medical imaging for snoring and difficulty breathing. This is a common, clinical scenario we see a lot, and we do the neck X-ray and we find that the adenoids are hypertrophied. But in this patient, there seems to be like something exerting mass effect on the airway on that side. And on the lateral view, we can appreciate the presence of a soft tissue lesion at the level of the epiglottis, and we cannot see even the aryepiglottic fold. So the patient was referred to do an MRI to further characterize this mass lesion. And this is the MRI here on the coronal images. We can appreciate the presence of this large mass lesion. And on the axial images, it is shown to be encasing the airway, and it is extending into the carotid space. And in the axial images, we can appreciate a little bit of a target sign, but there is no positive diffusion restriction, denoting that it is something which is low grade or it is a benign tumor. And this is the follow-up after 2 years after the treatment. And again, we can appreciate the mass effect on the airway. Let's take a look at another deep one here. This is a retroperitoneal plexiform neurofibromas, and you can see here that it is encasing the aorta and the big vessels. And this is 2021, and after treatment, there is some response to the treatment here, and there is interval decrease in the size. And maybe we are going to get a little bit later to see how we are going to assess the response for this type of the treatment. I'm going to show you the last case here for me. This is a child who has a disfigurement on the left right side of the pelvis, and you can see from the x-ray that there is significant dysplasia of the left hip and the left acetabulum, and MRI was performed, and it demonstrated the presence of a neurofibroma within the joint cavity in addition to the superficial neurofibromas. I just gave you a little glimpse of the many phases, the radiological phases of the NF1. There is still many, but it is not the scope of this talk to describe everything. And by this, I'm going to ask Nirav to continue with his slides. So let me stop sharing.
Thank you, Nagwa. I'll take over.
Can you?
Yes, I think I was able to do that. Can you see my screen?
Yes, I can.
Okay, great. So thank you, Nagwa, for so nicely giving us the visual highlights of what the imaging looks like. So as you know, visually highlighted by Dr. Wilson, plexiform neurofibromas can cause significant morbidity, such as pain, disfigurement, functional limitations, and compression of vital structures such as airway, which is sort of the most concerning that we get in clinical practice. And up to half of children with NF1, as we had seen earlier, will have plexiform neurofibromas. But of those 50%, it's around 20% who would need treatment in their childhood. And this is a beautiful natural history study which was done by NCI, which mainly looked at the natural history of plexiform neurofibromas and looked at various variables which could sort of identify the factors which we need to know. Interestingly, what it highlighted is that the plexiforms grow most rapidly in young children, if you can see on this part of the map. And the fastest growth happened in children which were less than 5 years of age. And this actually sort of even goes in with optic pathway gliomas, which have a very similar symptomatic presentation. And interestingly, none of the patients had spontaneous tumor shrinkage, which was defined by more than 20% during the period of observation. Although in optic pathway gliomas, we do see a spontaneous regression, as Dr. Wilson highlighted, and only 1/3 of them end up needing treatment. The second thing they looked at was, PN-related morbidities, and they realized that all the patients came in with at least some degree of morbidity at first assessment, and which was probably mild in most of them. But once a clinical morbidity developed in a patient that were growing, it was extremely unlikely to resolve spontaneously, and they always ended up needing treatment. So due to the significant morbidity which is associated with plexiforms, especially in early childhood, where their growth is pretty rapid, they would warrant some sort of treatment. So what treatment options did we have? So if we go in past, so surgery has always been an option. Surgeons have always helped out with most complicated stuff that we needed in past, but surgery has always been challenging for plexiforms, especially because almost 50% of them occur in very difficult locations, such as head, neck, face, and larynx, as Dr. Wilson showed. It is also associated with significant surgical morbidity, because a lot of times it is in close association with vital structures, and also they are quite vascular. So it's associated with significant blood loss. And whenever there is an incomplete resection, which is because of the above factors, then there's always significant regrowth, as you can see in the study which had shown. Anything below gross total resection, there was significant regrowth. Radiation has always been an option as well, like other low-grade tumors. However, because of the genetic germline mutation, they're always at an increased risk of malignant transformation. And therefore, this is a modality which we almost use it when we are pushed against the wall and almost try not using it. So that leads us to medical therapy, which is sort of the youngest branch in oncology. And as you can see here, we have tried multiple options. None of it has worked. So in past, all that we threw at, we tried to get to achieve some reduction. None of it worked. Until this landmark publication, which actually deserved NEJM, which changed the face of treatment of NF1. So this was actually a sprint study. And as you can see, this is recent past, where we were not achieving anything. And this is with the current therapy. And we are in the era of, designer drugs, where we are able to develop drugs to targets. And you can see the dramatic response, right? This is almost unreal. And these sort of things happens once in, lifetime, and you see such responses for diseases which were doing this historically. And this is exactly what we want to see, right? And this is what makes us happy when, as clinicians, we are working and trying to help patients in medicine. So just to finish the drama, this drug was selumetinib, which is a type of MEK inhibitor, and it was mainly used in patients with inoperable plexiform neurofibromas to see how we can help these patients. To understand how this drug helped us, it's important to understand the molecular phase of NF1. And as most of us know, it is NF1 is due to mutation in a chromosome on a mutation in the gene on chromosome 17, which actually encodes for neurofibrin protein. And this protein, in turn, actually regulates the RAS, RAF, and MEK pathway, which is a proliferative pathway. And when the neurofibrin gene has a mutation, that cannot deactivate this pathway, which keeps this pathway constitutively active and causes proliferation, which causes most of the symptoms that we see in NF1, including the tumors. And selumetinib is actually a MEK inhibitor, which is MEK 1 and 2 both, and therefore it acts this downstream in the pathway of proliferation, thereby stopping the entire cascade effect and thereby helping with not having the population. So coming back to the findings of the sprint study a little more in detail. So 66% of the patients who were on the study who met the criteria for endpoint had actually a response to treatment, which was unheard till this point in time. And the median time to the onset of response was actually 7.2 months, so around 7 months, and which is quick for a tumor which is benign to have response this early. And as you can see, this beautiful waterfall plot, right? This is what we want to see in most oncology kids when we use a new drug, is we see all the waterfall plots in almost the same direction. And the median percentage change in the volume, because volume was the criteria which was used for this study, was around 28%. The patients were treated for a median of almost 2.5 years on the sprint study. But more importantly, majority of the patients, as you can see, had improvement in their functional and patient-reported outcomes, right? Because if we do achieve a reduction in size, which we see by volume, is it translating to an improvement in the functional or the patient-related outcomes? And the answer for this study was yes. In fact, what they saw was global impression of change. Almost 86% of parents and 72% of children reported improvements in their plexiform-related complications or symptoms. So, and this is sort of the photo that you wait for. And as you can see, this was a patient at baseline who continued on the drug. And this is by cycle 10, which is each cycle was around 4 weeks. So around 10 months, you can see the improvement in the scoliosis because of the plexiform which was causing it. And this is what actually gets all of us emotional and so happy when we achieve these sort of outcomes. However, I like to caution that as the response is defined by a change in volume, in this study of around 20%, it is important to understand what it means, because conventionally, all our responses were based on unidimensional or two-dimensional imaging. And we need to understand that so that at onset, we are able to set the right expectations of the treatment for families and also for the medical team. So I will let Dr. Wilson now help us understand the same of how actually this is measured and how we are evolving.
Thank you, Nirav, for that. And as you mentioned, that the recommendations for the imaging of the tumor response, because the NF1 has a substantial morbidity, it is important to be able to assess radiologically how these tumors are going to respond. And for that, there was no standardized response criteria for the NF1 tumor until the tumor measurement working group of VRAINS have used the 20% volume change to indicate the decrease or increase in the tumor size. Can we move on to the next slide, please, Nirav?
Yes.
So in this slide here, we can see that these are axial IR images for a deep retroperitoneal paraspinal plexiform neurofibroma. And as you can see here, the tumor appears to be very ill-defined, very irregular in shape in order to measure. So what they have done is that they have done the imaging at baseline after 12 months and in 27 months. And they have used 3 methods of measurement. The first one is the one-dimension imaging. And as you can see here, it is from anterior to posterior. The second one is the 2-dimensional imaging, where they are using two perpendicular lines in order to measure this irregular shaped tumor. And in the third set of images, they are using the segmentation tool in order to measure the volumes. So they have found that in the first set, which is the 1-dimensional measurement, they have reached their 20% criteria after around 27 months. Using the 2-dimensional imaging, they have reached this 20% in 12 months, but using the volumetric, they have reached the 20% reduction in only 6 months. So I'm not very sure about the validity of the figure of the 20%. Maybe it is applicable to the 2D measurements, which we usually do in the imaging, but for the volume, I think it has to be correlated with the clinical response of the patient, and maybe some more work in order to assess another figure other than the 20% to use using this volumetric criteria.
Thanks, Nagwa. So as Nagwa highlighted, and it is very important to understand this aspect, as I was telling, is because conventionally, when the 2-dimensional responses or races were developed, they actually were developed so as to, it had a clinical correlate, right? So what we saw in 2D as a response, also visually we perceived as a response on the patients, and that was the way it was designed. Now, when we went from 2 dimensions to 3 dimensions, they kept the response same. Actually, they went down a bit to 20, and that sort of makes it a bit tricky, because the families, when they come and when they have seen these papers as well, where there are nice, beautiful plot, waterfall plots, they expect that this tumor is going to shrink and they're going to see it. Now and eventually, if it doesn't sort of translate to that, they get a bit disappointed. And therefore, it's very important to build expectations at baseline that we do see a response, and we will be able to pick up a response by volumetric assessments, but it might not be the response which might be very evident on clinical exam, which they would be perceiving themselves. Because in general, the consensus is that whenever you are translating a 2D response to a 3D response, it is usually between 50 and 60% that is equivalent of volumetric change to the one which was a 2-dimensional change. And we've had patients who have been disappointed. So it's very important to build the expectations. But as I showed in the study, what was more important is that majority of the patients had improvement in their functional outcomes and patient-related outcomes. So that is the thing we need to emphasize as a team amongst ourselves and also to the patients, that there will be an improvement in their functional and PROs, but obviously it will be a bonus if they see a significant change in their size. So just to set the expectation right for them. And moving ahead to recap then, why these patients need multi-D care. So as we know, it's 1 in 3,000 live births, the incidence of this, which makes it almost 2.5 million patients worldwide. 120 people are born with NF each day, which means every 12 minutes, someone is born with LF1. This is the magnitude of problem. And we already have seen the complexities that arise out of this and the multi-system involvement that this tumor might have. So as we have learned from the burden of disease and complexity, patients with NF1 have unique needs and need care from various specialties at different points in time. And just to see the burden, which might be in our area. So the last census of the OMR region showed that, in 2022, that we had approximately 1.5 million population, which roughly will translate to 400 to 500 NF1 patients. And if we leave the ones who have mild disease and might be doing otherwise well, almost 15 to 20% of the patients will have some sort of complications or advanced medical needs, which brings the number in our region to around 60 to 80. This is an estimate, obviously. And at present, we don't have an NF1 clinic at CHEO. So all our patients from OMR region either travel to Sick Kids or they travel to St. Justine to be a part of NF1 clinic. As you can see, the families already, especially the ones who have needs, the families already have so much of energy that they need to spend on the medical time that it's traveling for 4 hours or 3 hours to meet the physician is probably not in their best interest. And in fact, as of a couple of months ago, Sick Kids has stopped accepting patients of outside GTA area because they already have so much of volume that they cannot accept any more patients. So these are the patients who actually need a home here in CHEO. From the ones who are in OMR region, and we need to sort of help them out because we have got the expertise, we have got all the interested people, and I'm really happy and proud to announce that we have eventually, after 2 years, been able to put a team together of a really enthusiastic crowd who is very happy to provide help and support and a home to patients with NF1. And we didn't get the headshots of the 2 star performers, and that's why I've put them in diamonds, and rest all are actually in circles, is Dr. Alison Shaw and Dr. Asha Nair, who will provide the much needed backbone to the clinic from their pediatric standpoint. We have Dr. Katie Meir, who will be providing her neurology expertise, Dr. Sawyer with the genetic input, Dr. Malik, who is going to help out with the plastic surgery, the requirements that patients have. Me and Dr. Johnson will be helping out with the neuro-oncology part of them and also the plexiform neurofibromas, because now we do have a medical therapy, which makes a difference. Dr. Solin, who is going to provide the ophthalmology expertise, and Dr. Wilson, who's going to help us with radiology. We are obviously still always are happy to have more faces join the team, especially from dermatology and orthopedics, and we'll always be happy to be a family with all those additional faces as well. We had an earlier working group meeting for this clinic, and we have ironed out all the major roadblocks that we anticipated, and we are on track to start this clinic in September 2023 at CHEO. So going forward, these are actually the real faces of NF1. So we have seen all the faces of NF1 throughout this talk, but the true heroes, the NF1 heroes, and the real faces of NF1 are actually these patients who go through all of this and who have all these needs. And despite that, they every day fight in their life and survive and make a difference. So I think the real faces do need the clinic faces so that we can help them out better. And I'm glad we are able to make this happen, and we'll do this in September. So thank you. And again, May is the NF1 Awareness Month. So we'll break for questions.
That's great. Thank you so much. We're very fortunate to have experts and advocates like yourself at CHEO to do this building and hard work. Very evident that significant time and energy went into both the presentation and building that clinic that's going to start this fall. We'll open up for questions. If people want to raise their hand or just unmute. Maybe I'll kick off a question while people think and put their thoughts into words. That's a very impressive New England Journal study that you showed, as you mentioned. I did a quick look. Looks like it was published in 2020, and I was curious to hear 2 things. It looks like when I pulled that up, most of the recruitment was done pre-pandemic, 2015, 2016. Has there been any follow-up on the patients? It's been 7 or 8 years, I guess, since that initial work. What happened to the patients? Did they get to continue to receive therapy? Did the results continue to be as impressive? That's question number 1. Question number 2 is just if you can comment on cost.
Yeah. So thanks, Jar. I think those both are very important questions. And yes, that's true. We actually do have, obviously it's unpublished, and this is with, personal correspondence with the author, that they do continue to have continued response. In fact, what they noticed is that because they initially they reported only 66% response, but by the time the patients were 2 years on drug, 100% of them actually had a response. So that was great. And they continue to have clinical benefits even beyond that. And I think the last time they said was, they had a median time of what the follow-up we had was around 4 years. But the interesting thing is that these are newer drugs, right? These are the kinase inhibitors. And we right now don't know all the off-target effects that they might have on a growing body, right? So we do know the acute side effects, which, all these newer targeted therapies have, including selumetinib and other MEK inhibitors. But we are still early to know what long-term effects they will have on these kids who are still growing when they continue this drug. And the second important thing, which we don't know, is when do we stop this? Because there has been, again, from this study, there have been patients who have stopped the drug and their plexiforms have started to grow again. So we actually don't know, once we start this drug, when can we actually stop that? And which means that we are probably currently signing them off to continue it for life, or at least till we know the period where we know after which the growth actually slows down or stops. So I think those are two important sort of points, which I always highlight to the families, and it's important to know. And sorry, Dara, I missed your second question, or I sort of forgot it now.
It was about the cost of the therapy.
Yes.
And I think what you're talking about applies not just to this disease and this drug, but every new drug that comes out, right? You don't know, you know what maybe what it looks like year 1, year 2 in your trial, but what does it look like year 10, year 20? So that's not new for this. I don't want people to take it that way. And then the other, I was curious to hear about costs.
Yeah. So luckily the drug has been approved this January by Health Canada, and actually AstraZeneca and Alexion, which is a company which manufactures drug, they're working very closely with each provincial governments to get the drug on the list. And in the meanwhile, they actually have a program where they're able to provide this drug for the families who are not eligible for any route, either free of cost, or for the families who insurance might cover, but only partly. They also have a program which might help them cover the other part of the cost. So for now, actually, the access is pretty much straightforward to get. And not just this MEK inhibitors, we have even other MEK inhibitors in market. I didn't show because there aren't published data. There are very early phase studies, but all of them show very similar responses, and we do have access to them. So it's easy, and currently has no significant cost burden on family to get those drugs.
Okay, it looks like we have a couple other questions. Maybe we'll start with Dr. Batra, and then there's a few in the chat.
Yeah, thank you very much. It was a very impressive talk. I was wondering if there are any markers or other predictors of the disease that is going to go to develop the severe disease. And suppose even if you know that, what will be your approach there? Use surgery, radiation, or the medical treatment?
So thanks, Dr. Batra. Actually, this is a great question. And this is the general sequence, right? How you will proceed with the kids once you find something that might be helpful. So to answer your first part of the question, we are still learning about genotype-phenotype correlations, and there are not very strong correlations, except we do know that with microdeletion syndromes, which is sort of deletion in the entire part of the gene, we know that there is predisposition to severe disease, including a greater chance of developing MPNST, or the malignant form of nerve sheath tumor, which is a malignancy. And it's interesting because NSA is already looking at a study where they are going to identify kids who are at high risk, which would be these ones which we know genotypically who already might be developing those, and the patients who are younger and having neurofibromas at really challenging locations, to actually prophylactically start them on MEK inhibitor. And again, the drug on that study currently is planned to be selumetinib, and see that does it make a difference for them going forward, because we know that once the comorbidity sets in, it's a little challenging, and we have had patients who have ended up with tracheostomy because of the plexiform which is there in the laryngeal area. So yeah, I think it's a very exciting time overall in oncology, and also for NF1, because we have a few drugs which are changing life for these patients, which are not available before.
That's great question. We have another hand up. Sophia, do you want to go ahead?
Yes, thank you so much for just an amazing presentation and, very stimulating and well done. And also congratulations for getting your clinic, going. I think it's very exciting. Now, you did mention that 50% of these children will have some type of neurocognitive deficit. And I can tell you also that there is significant comorbid psychiatric association as well. How is your clinic going to do some screening and from early on address the needs of that population? I'm very interested to know.
So thanks, Dr. Isco, and thank you for the kind words. So at present, Dr. Isco, what we are trying to do is, because already it was, it has been a significant challenge getting the entire team together. We are currently actually starting with only the ones with neurology and as oncology, we are identifying the ones who might need treatment. And obviously we have Dr. Nair and Dr. Shaw with us, who are eventually, as the clinic progresses. Right now we are planning to only 1/2 clinic a month, and we'll start with that. It's mainly to get the ball rolling and see how the clinic starts functioning. And actually, that's a great point, because our long-term vision, and we discussed this in the meeting yesterday, we also have a tuberous sclerosis clinic, if you know, right, which Dr. Muir, me, Sarah are a part of. So our long-term vision is actually to have an umbrella of neurocutaneous clinic at CHEO, which we will then be able to get more resources as the entire clinic to get additional resources from neuropsych point of view, as well as, from management, nursing point of view, to have a bigger clinic to support these additional needs of this patient. Because we know this is in no way that we are covering everything for them. This is a beginning, and we have a long way to go, and we have that in our milestones going ahead.
And I'm just add to that the numbers say 50%, but a lot of those kids will have mild learning difficulties, ADHD, very typical issues that are common in the population, 20 to 30%. So those children will remain to be followed by their family physicians. And it's the ones who have more severe needs, who need, psychoeds and things that eventually, hopefully, we'll see.
Just think that, integrating from, as early as possible is often very helpful in supporting the optimal growth of the youth and for the parents as well. So thank you.
Lots of great questions and engagement. I'd be curious, Dr. Wilson, Dr. Thacker, or the other people that are involved with the clinic on the line. Can you share with us if you can, the time it took to, like, from when you started sort of agitating and advocating around a clinic to the fall? Just as an example, like, my experience is you definitely can make change within the hospital and broader. It does take time. So yeah, can you give us a sense of what the timeline was? So people.
Thanks, Dar. You touched an emotional chord with that. So actually, the vision for the clinic was even before I started at CHEO. So I had a conversation with Dr. Johnson in my interview where we said, where I had said that, once I'm there, my vision was to start an NF1 clinic. And I always envisioned that it should be a multi-D clinic, because the current clinics in Ontario are isolated NF1 clinics. It's not a multidisciplinary clinic in the same setting. So I was envisioning something where, the experts who need to be there, especially neurology and oncology, are a part of the clinic with pediatricians. And this started before I came to CHEO, so before July 2021. And then, yes, we had pandemic, we had the surges, the viral surges. And as I said, the pediatricians are the backbone of this clinic. So we had to go through a lot of hoops, multiple actually meetings with Dr. Parkins, who is the NF1 expert at Sick Kids, who was also trying to help us, to see if, answer the questions if pediatricians had any of what the clinics look like and what it goes. And so it's been 2 years that we were able to get this. And this is all thanks to Dr. Shaw, who got back to me. So we had spoken before the surge that happened in this winter, and she got back to me immediately at the end of the surge saying that, now Dr. Nair is ready and they both are happy to be a part of this clinic and be our spine.
Thanks for sharing that timeline. And I don't want that to be discouraging to people. It's just can take some time. There's a law that says it's going to take longer than you think. Remember the name of the law, but I can't off the top of my head. It's going to take longer than you think, even if you take the law into consideration. So well done. It can sound easy, but it takes a long time and a huge effort. So we're at 9:30. If there's any, we'll maybe take one more question. I see people are starting to sign out and head off to their daily work. If there's, we'll give 10 seconds for a last hand. If not, thank you everyone for coming. Thank you to our speakers.
Thank you. Thanks, everyone. Thanks for your time.
Thank you.
Okay. Have a great day, all.